Man, I should have done bring a friend because Todd is a friend. But anyway, we're here today on Planetary Health First, Mars Next, and I got a podcaster master, Todd Eury. No, nothing to I guess introduce you with because you are known. I mean, you were like the grandfather of the internet of podcasting.
Thank you so much. And I'm so excited to be here. I've waited to be on your show. So I've been watching other people that are in our collective professional circles show up. And I'm like, I got to get my time with Michael, man. I think it's like it's if you get you get an extra status if you get on the show. So I'm on it now. So I'm excited to be here.
And just to let our viewers know, I'm not paying Todd for any of those information bites. I thank you. I don't know why you're stroking it like that because as you see on mine, I want to show everyone my backdrop.
Came through, or the Cash App came through like 10 minutes ago.
I don't use that. I use Venmo. I use others. So anyway, but I love your backdrop. It's just awesome. I'm having podcaster FOMO versus mine. I'm going to get there one day. But look at my little backdrop. If you can see it, Planetary Health makes me.
Erase boards are still, I think it's a generational thing. I don't know if are you a Gen Xer?
I am barely. Like I'm a
late Gen Xer.
Yeah.
But you're still part of the club. So I do things that I'm now finding out are extremely boomerish or Gen Xerish from the whiteboard. I love whiteboards, right? I've always used them. I'm a talker. And then I'm always the younger generations that have worked with me that matter of fact, we don't even have my main whiteboard up in our area anymore because I've been forced to accept some of the next way of doing things. But I like a whiteboard. I'll always be a whiteboard fan.
The problem is I'm in my post-COVID guest room, which has become my office. And it's just still like, it was awful when we had great friends over, like around Easter weekend. I had to clear out. I use my side office as the trunk of my car to put it's just awful. And so literally I had to be rehoused when they came. There's a guest bedroom. It's we have a little small house, but one day I have aspirations for a studio for functionality and creativity and to do my art. And I love what you've done. And, I love being able to, the fact that we talked a while ago, we've talked a few times, and just, I don't say that lightly that there's so few people that have been in this business for the level and time like yourself. And it's no easy feat to grow an audience, to create value.
It's horrible. It's still horribly hard. It's very hard. The podcast game has just leveled up. It's not, what we do is not about podcasting. What we do is about amplifying the voices of a healthcare provider who has not had the kind of media exposure that impacts a public's reaction to fill in the blank: addiction, diabetes, hypertension, rare disease states, medical cannabis, psychotropics. Like all of these kratom, all of these substances that are inside our public that are being used by prescribed patients, being used by the street patient that is self-medicating, the casual user, the recreational user. What people don't understand is we don't talk enough about what pharmacists actually do, because it's always about the white coat standing behind the counter at a Walmart or a big box store or even an independent store. No, the dispensing aspect of pharmacy is disappearing. Now, it's not completely gone. There's still some things that are happening, but using a pharmacist to dig into what's going on in your life, your caffeine consumption, the mixture with some holistic medications that are coming out and being sought after. I just mentioned CBD and the cannabinoid. See, I'm not a pharmacist. I can't say these complex terms. But all of those systems play into how someone lives, how
Yeah.
they're feeling from a mood perspective or stress, and we're finally dialing into what pharmacists are truly supposed to be doing as medication experts, not only for the patient, which is the most important part, Michael, but I'm talking about insurance companies,
Mhm.
about PBMs, I'm talking about the pharma manufacturers. The pharma manufacturers are starting to really shift their medical science liaisons to being pharmacists
Mhm.
because it's like a two in one. They get a two for oneer employee. They get a PharmD who knows exactly what's going on from a pharmacological, molecular, pharmacogenomics perspective interaction, and then they get this representation of their company to physicians and to
Mhm.
researchers that present themselves at the highest level of education even possible in the realm of medication
Mhm.
knowledge. And so that's exciting. I get to be the first podcast back in 2009 that launched about the profession of pharmacy.
Mhm.
And today we are a global leading publication, not because of me. I am the Jerry Maguire. It's because of my
Mhm.
superstar athletic level professional podcasting pharmacists
Mhm.
that are taking themes, and I get to become the network builder of their brand, of their names, of their messaging. And it's just been it's to be here finally after 15 years
Mhm.
of still, struggling to maintain and to grow and to compete with other messaging sources. It's a blessing. So I'm excited.
Well, I think just hearing what you're saying makes me feel excited because you really better describe the value of what a pharmacist is and what pharmacy is. And when I think the topics that get me excited with Planetary Health First, Mars Next, like we're having someone air today on psychedelics and death and dying.
Yeah.
And it's just fascinating. And she's not a pharmacist, but all this is research driven, research based, and all the different treatments to heal those with cancer or dying, with the anxiety, all the different things. And so a lot of the topics that and everything I try to do, I'm trying to, put out there, it's a disclaimer. I'm not a for or against. I'm just curious, more on a journalistic pursuit to try to reimagine healthcare, try to help those conversations. And but anyway, I know just how we've started. We're going to have to do this another time. So you're going to have me. I guess if you don't ask, you won't receive. So I'm telling you today, live on the air, I need to be coming on your show, right? I
Yes.
guess that's fair enough. Is that the trade in kind?
Absolutely. So we have a show called This Week in Pharmacy, and it's like our catch-all show, and that's where you belong. You belong on This Week in Pharmacy, and come on, and we'll discuss any theme or topic that you want to dive into because
Mhm.
it's all relative.
Cool, cool. Well, one thing that I'm really fascinated by as a son, my father has dementia, he has heart failure, he's in a hospice. And I do believe that, and this is probably outside your realm, but I feel like there needs to be a better decision-making process amongst healthcare, amongst care providers. I think about 3 years ago, he could have entered an at-home care where they could have provided, because he wasn't a candidate for heart surgery. He wasn't a candidate other than IV drips when he's dehydrated or constipation. I mean, why are older adults going? We're not really sure, but they're doing a CAT scan and an MRI for what? I mean, so it's just sort of, I feel like that talking about, and our topic was transformation of healthcare, if you will, or pharmacy. So, I mean, I think that to me is a huge topic if we're talking about the care spend, which sadly enough, the healthcare pie, when you look at all of this, and you probably could quickly bring up the data point, it's the same percentage of the pie from 1961. Someone shared with me this. Like when you look at the SNF amount of the pie, the hospital, the pharmacy, if I'm not mistaken, it's the same slice of that pie. It's just a bigger pie now in 2024. That blows me away. If we have the same parts of, whether it be so that to me is just like something, yeah, we're all wanting a little bit of it. And so no wonder the spin. We're just making a pie bigger and keeping our slice, I guess.
When I entered healthcare, Michael, in 2004, in the long-term care pharmacy technology space, so it was all is all about software that would run a pharmacy that was specific to geriatric care and senior care. There wasn't a lot of talk back then about how important the mental health segment of healthcare is to everything else. There were these strange, invisible border walls between different segments of healthcare, and mental health and everything else never crossed very often. And if you had a mental health disorder, it was a stigma, and you were shamed, or you felt shamed. You felt like there was something that you couldn't talk about. And how many people were dealing with depression? I know my own family, my father, my second brother, my oldest and my second brother, we've all experienced levels of stress. And what I identified that stress when I was 12, or when I was 16 or 20 or 30, actually it was into my 40s, really, where I didn't know, wow, that's a thing, like mental health, anxiety. So today we're paying so much more attention to that. And kudos to the management team, helping your loved one with dementia, because dementia is that's a spider web of all things that could come up. Or medication management, that's psychosis support, that's physical interaction to get them, because they say if you keep someone active and you get blood flowing through them, it helps to decrease the outcomes of dementia. Nutritional, environmental modifications, this caregiver support, like that whole dementia is a whole space within itself. If you don't have a pharmacist dialed into dementia care for the individual instead of rubber stamping it, I mean, you're missing out on a whole way that the pharmacist could really help control. And I can't wait for psychotropics to go microdosing. I can't wait for CBD and vitamin Bs and compounds of these creative pharmacists who are like little chemists. They are chemists, that they will put something together specifically for me when I get them, if I ever got dementia someday, dial into how my body metabolizes, understand the pharmacogenomics of it, by making me take a DNA test to know exactly how fast I'm absorbing medication. Like, this is the future of where pharmacists are going. It's wild. It's going to be better to be a pharmacy today and the future than it ever was, 20, 30 years ago, because of finally we're going to get to some of the sweet spots of what a pharmacist is actually supposed to be doing.
Have you come across Dr. Nolan Williams? Any of his stuff?
Dr. Noland. I know a Dr. Noland, but I don't know if it's the same one that you're speaking of.
So he's out of Stanford. He's doing the Saint treatment. That's the TMS, and it's fascinating. With after about 5 episodes, the duration is about potentially about a year and a half. We're just stopping depression in its tracks. He's doing all these different researches. Psychedelics is one of them. Just really on the forefront in research and breakthrough of how we engage mental health.
Let's get him on This Week in Pharmacy, and maybe that's how we get you and me and him all together on an episode.
Yeah, I'm having trouble. I think when you get in touch with the PR people, it's the blocker. I hate to say it. It's like, then they look, so how many impressions, so yeah, I would. So
we'll tell them our metrics. What we have, over 100,000 listeners, and
all right. So let's do that. I'll see if I can bring a friend. We'll bring a friend on your network. And he's already a friend because, I guess it's unrequited friendship. I've been starting to listen to his stuff. It's just fascinating. And like, he brings up stuff that would just look so off the wall, but it's research oriented, such as like the ibogaine. I don't know if you're familiar with ibogaine. It's a root out of Africa, and it's showing a lot of promise with substance abuse, with traumatic brain injury, and also post-traumatic stress. Like, a lot of these veterans, Navy SEALs, the most severe, like, badass, excuse me, I guess we're explicit now, but those type that go down to Mexico and they've literally all their scores by research, all those WHO metrics are just literally hugely reduced by his research, or not. This isn't his per se, but the research that they see on the follow-up studies of these, and then these individuals are saying to their friends word of mouth, look, I'm able to function again and all this. So and that's on ibogaine, which is it's used for ceremonial, and it does this imagined really powerful effect of participant is able to step back from their life and review those traumatic events like early on or wherever it was and be able to reconcile. It is just fascinating. So I'll stop there. So anyway.
No, ibogaine. I thought you said I wasn't sure, but ibogaine is a naturally occurring psychoactive substance found in the plants in the family, such as the Tavernethian aboga, and it is psychedelic with dissociative properties. Excellent. Yeah, this would make a really good episode. I think we should go after the multiple.
Yeah.
It doesn't have to be just one person, because this, that's what I really like doing. I like finding innovators in medicine and bringing them on to get that word and that message out to pharmacists that are plugged in, because it turns these pharmacists on fire to basically encourage them to do something that they really want to do. There's so many pharmacists that are feeling stuck right now because of the macroeconomics of what the PBMs have done really to healthcare. And that's a whole nother episode, Michael. But the frustration is now causing them to say, why did I become a pharmacist, right? And if they take a step back and look at all of the capabilities of what they have, and then they go out and they think, what am I really interested in? Meaning, if I'm working at a Walmart, pharmacy, community pharmacy, and I really have a desire to work with children only, pediatrics, right? Pediatrics is exploding right now for pharmacists, led by people like Dr. Jennifer Quinn, who runs, Perfecting Peds. And now Perfecting Peds is contracting with MCOs, managed care organizations, across the nation, so that they can dial into the specifics of some of our sick children that don't have oversight from pharmacists on a regular basis or an intense basis, based on maybe like a specialty or a rare disease or something that's very specific to that child. So the reason why I'm bringing that up, I mean, you could say, do you love corgis? Because I have 2 corgis. I love corgis. Do you love cats? Do you love become a veterinarian, dial into the veterinarian space of pharmacy? Do you like business and administration? Would you rather become kind of the guard for a major company that's in medical research? There's a whole organization that just signed up with us called FactMI. FactMI, you can find them at factmi.org. But FactMI is a medical research and education collection company, pulling together all of this medical information for specific situations that are public health facing, and it's all driven by pharmacists. Like the element of healthcare is changing, pharmacy's changing along with it, and it's really time to take it away from the administrators, take it away from the insurance companies, and give it back to our physicians, and give it back to our nurses, and give it back to our pharmacists, who are just passionate about taking care of people, and get out of their way. Like, pay them, make sure that things are balanced, and trying to keep costs low. But Michael, our nation, the United States of America, has been hijacked by insurance companies, and they're putting that first instead of putting the patient first. And if you put the patient first, that means that the physician's in charge. That physician is the quarterback, and then he or she has specialists surrounding them. The nurse, the medication expert, and we could go on and on. But we have to return to patient-focused healthcare and not just a buzzword. Like, we actually have to do it.
Yeah, I think you really when you it's just very common sense when you experience healthcare as an individual, as a patient, consumer. You can see, I have been able to see, witness, I would say right into COVID to now, pharmacist stress level, I would imagine it's probably 80% heightened, just burned out. But before, I could remember 5 years ago, even though they're like, it's ridiculous. I mean, if there could just be a pill counter and just swap it in and put it in, I mean, that's where AI should be. Just no more counting pills. We'll do it for you. AI. Gosh, if that was a robotic AI that Amazon would license, my gosh, that to oh, don't take my word. That's a company right there. But they know the stuff. And I know this because I used to have a care management company, and nothing against doctors ordering all these tests and medications, but man, at the point of care when these older adults are going, so many medical errors or pills that seniors are contradictive. Should it's that pharmacist that's like, whoa, 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 we need to get you on the right medication. So it just seems like, if the regulatory, if the right frameworks, whether it be like you said with MSOs or ACOs, that are able to have some looser, more smartly created network of how you make these decisions, when there's value aligned in that pie, I would see that that could be a good thing. But that's a whole nother show, I guess, right?
It is a whole other show. But yeah, I think we're seeing some change. We're absolutely seeing changes. Changes are happening with or without permission. Pharmacists are now doing things that have never been done before in digital health, digital therapeutic, AI design, AI control, treatment management, and modality changes. The balance now needs to come back to how things get paid for, how things are being paid. So the difference is a dispensing fee, whatever it is not the future of the pharmaceutical and pharmaceutical management space. It's the value base, and it's paying a pharmacist just like you pay a doctor in paying them to provide care. And stop talking about the dispensing fee, because that's silly, and that's more automated, it's more technology, it's more packaging. That's fine, that's a component of it, but start paying the pharmacists for the expertise that they bring to the table, that they're really giving away most of the time, especially in
Mhm.
the community pharmacy, independent pharmacy space. Shout out to Sean Naran here in Pittsburgh, Pennsylvania. I mean, that guy's a champion for
Mhm.
his patient, and
Mhm.
he saw something happening because he started in hometown pharmacies, which is a grocery store kind of connection pharmacy thing. And then he's like, that's it, I'm creating my own thing, because I see that there's a bunch of people in Carnegie, Pennsylvania, that live in their homes, and it's very hard for them to
Mhm.
get out of their homes or go places. They're
Mhm.
older people. He has literally surrounded his community with his with Acore RX in servicing those people where they need to be serviced, which is in their home, and delivering in their home, and making
Mhm.
sure they have extra things happening. He might be moving forward with like remote patient monitoring and
Mhm.
some other things. And obviously Happier at Home, which is a partner of community pharmacies, they're now embedding caregivers like bathing, cleaning, a little bit of shopping into the mix, so that
Mhm.
the pharmacy knows exactly what's going on with the caregiving. And now these two organization types get to constantly communicate. Now that's the kind of healthcare I want my grandma or my mother to have someday. I don't want her at a nursing home. If
Mhm.
she doesn't have to be in a skilled setting where it's like super intricate and complex to take care of her, if she's just the average, senior, and she's doing okay and she needs like assistance, I want her in her home.
So Todd, I love Sean. He's a good buddy of mine. In fact, we need to thank him. He's a bring a friend. He's the one who connected the two of like you and I together. And I've had him on, and I don't know like his company, but I know enough. And we talked several times. You and I were spitballing, trying to figure out how we could collaborate. And it seems like every city locale, I know he's in rural Western Pennsylvania, but every city locale should have that kind of service. And I know I've seen the big companies say they deliver at home, but I could only imagine what that looks like. Yeah, Amazon, they drop it on your doorstep, right? I don't think it's to the level of the packaging, the medication reconciliation, the supervision, and then that kind of concierge effort. But when I'm dealing with my father who's 91, we're lucky that we have a caregiver for 36 hours through a long-term care, 36 hours a week, which leaves still a Sunday that we don't have that. And then my mom in the evening, it's a ton of stuff that needs, but that biggest thing is that medication management. So anyway, I hope to hear more about what Sean's doing and more of that, because I think you're absolutely right with what needs to accelerate, taking care of people, and so anyway.
Yeah, absolutely. And so what Sean's developed is a little ahead of the curve. He's a high performing pharmacist. He's not the average bear. But what he was doing 10 years ago in the whole conception of ACORX is now spilling out into some of our other independent community pharmacies where they have opportunities to make these small little assisted living center like conduits, hub and spoke to their operations and to their workflow, and letting people's homes become an extension of a long-term care pharmacy environment where now you're treating the home as almost like an assisted living center in and of itself, but except they're mini, of course. And there is a whole business model and a rush to deliver services in the home that include finger, monitoring, pulse monitoring, and things that might, rate your heart or take into consideration your heartbeat and blood and anything else that can be kind of plugged into technology, which really makes me think of the theme of your show, and it really brings to light that if we could just return. See, I'm combining. I say some things that we have to return to healthcare and in concentrating on the individual and giving them true care. Dropping a package on the front doorstep is not healthcare. I mean, if you're on a maintenance med and you're a completely healthy person, you just have a med coming to you, once in a while, every 30 days, whatever. I get that. And I'm a convenience person, so I understand. But I'm talking about the are sick. I'm talking about people that need a human being to slow down, stop putting them through fast food medicine, stop, treating them like a number, hold their hand, maybe look them in the eye and just ask them, how are you feeling right now? Like literally describe to me in detail, how are you feeling? Like what's going on? And some of that, Michael, has nothing to do with medication. But if you have a pharmacist that can listen to that feedback of that patient and assess other things that are going on in their life, that pharmacist can dial into that. And we're not taking advantage of that at a level that we should. And we're going to have to combine tech with pharmacists in the communities. And you said rural Western Pennsylvania. Sean is in Carnegie, which is right up against massive Pittsburgh. So he's not really in that much of a rural area. Whereas me and Fayette County is like super rural. I mean, we're talking about mountains and big forest patches and stuff. So my area is in desperate need of a community pharmacy to kind of adopt what ACORX has built and kind of bring it down to Fayette County, because there are a ton of seniors here, not to mention 11,000 people every day in 2024 turn 65 years old. So if you want to make money, by the way, and have a heart in medicine, get involved in senior care, because for the next 10 to 20 years, it's going to be a rocket ship to Mars.
And I also hear, like, a lot of people aren't aware of that within that number that's quoted, whether it be 12,000, I think now a day is the number I'm hearing for Medicare. The biggest, fastest growing is 43 to 53, and that's the disabled market within that is eligible through Social Security. So that's a whole nother thing that probably, most of that I imagine is behavioral health.
And listen, we are now mixing in an extra 7 to 9 million people, whatever it is, when people are flooding into the country, and they're human beings just like everybody else. So they're going to need stuff. They're going to need health care. They're going to need, and there's no politics in this statement. It's just talking about human beings being cared for. Whether or not they should be here is a whole nother podcast. But we have to understand that pharmacy services are not increasing in the United States. They're actually collapsing. And you have to be a responsible, you are in healthcare media. Okay. So you and I as publishers, we have to be responsible publishers to point out what is wrong, even though it's tough love, with pharmacy, and what is wrong with healthcare, and what is wrong with insurance. And we got to call people out on the carpet once in a while. And we have to say, hey, we don't want CVS Healthcare, or we don't want Express Scripts, or we don't want OptumRx. We don't want you out of business. We need you to be in business, and we need you to be a profitable company. But to be putting out $140 billion in profit, CVS Healthcare just put out 2023, 140 billion. That's 12% increase from 2022. Their profit, not their revenue, their profit. And pharmacists are burning out left and right. That's number one. Number two, CVS is closing stores all over the United States because they cannot put up with their own reimbursement model. It's literally putting their own stores out of business, and they're closing massive stores that are in communities that desperately need pharmacy care. And that's unfortunately, I'm not soapboxing because this is all based on fact.
Data.
It's based on data. It's published. You just go out and search it. If we don't get big organizations like that straightened out and basically back in the game, because they're out for themselves when you start talking about 140 billion in profit, but your pharmacists are quitting because they can't stand working for you because they feel like a fast food medicine person. Like that all needs to be corrected. We need CVS to be the CVS that they once were, and really starting to concentrate on their patients first, and their pharmacists and their technicians and the communities that they serve, and not this crushing, putting independent community pharmacies out of business because of the way that you do business. It's just not right.
Well, I think my thought would be, if we have more innovation, more support initiatives for the ACARX or the Sean Neer kind of companies to really spur pharmacists that maybe not by birth or by design would be entrepreneurial. But I feel like, rather than asking these big monolithic structures to change out of the kindness of their heart, I would say, if we could have some like little hubs, spoken hubs with entrepreneurs and small business to drive greater community engagement.
A business model that I see coming, based on what's already taken place, is returning healthcare to the local level. All right. So there's a guy named Brandon Antonopoulos, Dr. Antonopoulos, in Beaver Falls, Pennsylvania, or Beaver County, Pennsylvania. And his grand opening of his pharmacy opens up on May 24th. Okay. Coming up. I'm going to go 11 a.m. and I'm going to be there. And he was the previous operations director for CPESN, which was the Community Pharmacy Enhanced Services Network. He was the chapter of Pennsylvania. He led their whole division of clinical based, getting pharmacists paid for clinical services. Now that guy is opening up his own community pharmacy using the same strategies and tactics. And here's the punchline. You ready for this? He's 100% cash based. He's going to take control of his locale's pharmacy services and pharmacy spend, and he's going to save his patients thousands, millions. He could even go to a school district and have a one-on-one contract, right, with the school, and be able to revolutionize the expense that local governments spend on pharmacy benefits that go to organizations like, these big, huge PBMs that they think this is the way it has to be, and it doesn't. So there are cash-based physician organizations. There are private insurances now popping up. There's organizations like RX Preferred Benefits. That's a new kind of PBM that works with pharmacists directly. And there's a retaliation going on that we're going to see increase, that we're not going to wait around and wait for big monolith like Goliaths, that, like you said, to be good stewards of healthcare. We're not waiting.
Well, I'm going to tell you, we're not waiting, but you will see CVS will change their name. It's like, what was Anthem? Now it's Evolent. So CVS will become Health Havana or something. Who knows? You know, that's the only thing that changes is
So,
the name,
so
right?
think about this. Think about this. So if we had right now cash-based pharmacies throughout the United States, I bet you there's less than 20, maybe less than 50, but definitely not very many, right? Imagine a Mark Cuban who loves punching, the whole PBM industry in the face with his Mark Cuban cost plus drug. Imagine if someone at his size coming to the markets and saying, "We're going to create cash-based pharmacy models all across the United States. We're going to be the wholesaler. We're going to be the administrator, and it's just going to be about the community, and you can pick up your franchise, your cost plus, like Kyle McCormick calls his blueberry pharmacies, but you could name it whatever you want. But now it becomes just like there's Health Mart pharmacies out there that are part of McKesson. There could be cost plus pharmacies out there. You can call yourself whatever you want, blueberry cost plus pharmacy, and now you're part of this national network of cash. I mean, it's reinventing. You can see cycles, right?
Well, I already have an idea. You got me spinning. I'm not a pharmacist, but I would see like my dad, who's 91. I've referred to him too many times, but he used to be the soda jerk. You know what a soda jerk is?
No.
So when he was a boy, that's what the one at the pharmacist, the local drugstore, it's the person who made those root beer, those
Oh,
drinks. And
yeah.
so I would see the way to do this is you partner and collaborate with the right, whether it be a black rifle. Imagine a black rifle, coffee or something, some sort of retailer, whatever, local eatery, and you have a pharmacy or something or product. There's got to be a better way because people are really open for
Change.
community. They're open for to be a part of something that people care and it's real. And we, this insurance, you always are ending up paying, and it's like, RX, good RX. It's like that's great. And now it's still, it's like anyway. But I think we do need and I would imagine cities and schools and different communities like those elements would, but then I don't know because the insurance, those big group insurers have a lot of power on it. So you'd have to be very nimble and clever how you strategize with it. So
Yeah, the big organizations are seeing cracks in the business models based on profit being pulled out because organizations are not, communities and organizations are not doing the status quo anymore. It doesn't have to be just one way. It can be a mixture. And I think it's good for a community to find its mixture, to find how to dial in to a community with services that is personalized. And I don't want to see community pharmacy suffer and independent community pharmacy collapse any more than it already is in the States, because we're less than 18,000 independently owned community pharmacies, and it's having a massive detriment to parts of the country that are pharmacy deserts that don't have any health care, for 20 miles away, 30 miles away, because these small mom and pop pharmacies can't stay open based on what PBMs have, the three biggest of the PBMs have created, which have crushed them and have put them out of business, thinking that it was, whatever boardroom decision that was made to try to say, hey, we're going to save money by going to mail order. No, there was an economic effect on what you've done over the last 10 years. And now, by the way, Michael, not to be a doomsdayer, but this is just starting. Okay. The collapse of pharmacy services in the United States are starting. Even if you did the right thing right now on, whatever time it is right now, it would not change what effect this has had. So we're going to see some very hard times in communities without pharmacy services for the next 3 to 5 years, while the population is rising to 344 million, right? And then our seniors, as we just got done saying, those numbers are exploding. We're going to be up to 23% of our United States population is going to be over 65 years old. They say in 2040 or 2035, 2035, 2040. So that's scary, that if we don't have the right infrastructure in place to start caring for more people, you're just going to exacerbate the problem and all the expenses, because you're going to have people going into the emergency room left and right. So A shout out to everybody listening, especially our pharmacists. You're my favorite providers, but understand that if we don't at the ground level, at the grassroots level, start talking more about this and educating your father and your friends and and our listeners and to what's really going on, like we have to change things, and it can't be the next guy. It has to be me. So I'm gonna take it. I take it personally.
Mhm. Cool. I love this. I love your passion. I love everything you've done to get yourself there to be informed, because passion without information and data is not very helpful. Um, and do you, I know we're coming towards the end, but we still have a little bit, I hope. I feel like the last 7 minutes is where it just pops. So I know we're going to have a pop. Is there anything else we want to kind of get dial in before we go on Mars?
No, let's head to Mars. I'm excited about the rest of 2024. If you're listening and want to work with me and our 50 plus hosts that are experts in so many facets of medicine, from digital therapeutics to hyperlipidemia to oncology to childcare, addiction medicine, come work with us. I always say #TogetherRx.
Wow, 50 plus hosts. How did that start? I mean, I'd love to know the trajectory. I bet you it took a while to get that 50, or that first or two, and then that three. I'd love to see that time chart over, but you don't have to share that. We're getting into some IP stuff, but anyway.
Yeah, I'm excited about our future, and I feel like it's just starting. We're getting collaborations with organizations that are in really amazing positions, Cardinal Health and digital companies that are working with us, the FDA, Novo Nordisk. There's all these organizations that want their content to get out. They want it done professionally. They want it pushed to pharmacists because they're recognizing that pharmacists are truly helping to lead treatment. And once the baton gets handed to them by the physician, the prescriber, they go to town and they work for their patient.
Wow. So you got a really powerful audience, product market fit. I hate that word but it really um, says it well. And Todd, I'm so glad we could connect and talk more about this. And I think we're going to have to do another one. I will follow you up on trying to get the gentleman, Dr. Nolan Williams. I'm going to bring myself, since I'm a friend. So we'll get him on your show together. Do I have you on air? Is the air document in this conversation that it took place? Do I have affirmative if we can get him on?
Air document has been signed.
Because I mean, that's the power of your network, and I think he would be an amazing guest. If just I will share with you a few links. He's on the biggest of the biggest podcasters. Not that yours isn't big, but when you mentioned Tim Ferriss and the Huberman Lab, I don't know. I mean, anyway, but he is cutting edge research, and all this is driven by research that is going to go to pharma in the end, where it's implemented, and so it's so important. So I guess that's my little thing, is just trying to accelerate these conversations in healthcare, and I think we're at that moment in time.
Excellent. Let's go.
All right, until next time, my friends.